go ahead and get started with some introductions for the evening. Again, thank you all for joining us. My name is Adam Gross. I'm a second-year medical student here at Albany Medical College, and I am going to be a co-president of the Albany Medical College Community Grand Rounds group for next year. So again, tonight we have a really exciting collaboration between students from the medical college as well as from the law school. So we're thankful to all the student participators, faculty commentators, and to all of you for joining us tonight. This is really an example of a project that is just the epitome of what we really hope to be able to accomplish with Community Grand Rounds. We really want to empower the student community, to empower students and colleagues from the different interdisciplinary programs to kind of join with us and to talk about these really critical topics in medicine. And I think what you'll see tonight, we got a sneak peek last night, is just a really passionate group talking about a topic that we can really start to make a change. And I think they're really going to talk about some exciting topics and ways that we can really make a difference as clinicians. So with that, I'd like to turn it over to Isha.
Hi, everyone. Thank you for joining us today. I know the weather is great outside, so thank you for taking the time to joining us today. I just wanted to start off by explaining the inspiration for today's presentation. As medical students in our second year, Albany Med teaches us an intimate partner violence clinical skills session, in which we're taught in a 15-minute interaction with one of our standardized patients about how to address issues of intimate partner violence or domestic violence. And as a medical student who went through that session, while I generously appreciate that it is involved in our curriculum, I can say that walking out of that session, I don't know if me and my fellow medical students feel prepared enough in talking about those kinds of traumas, or even providing the correct resources for when we see a patient that has those experiences. And starting from there, we started contacting Albany Law School, and we met Professor Barrett, who will be introduced later in this production. But essentially, we realized that we need to focus a lot of our efforts as physicians on not only screening these victims, but also in implementing the strategies that we learn. As a medical society that's evidence-based and moving towards a field where we want to study ourselves, there needs to be a shift in the medical literature to looking at how those implementation strategies are actually working in the status quo. And so based off of that, we present to you intimate partner violence, the role of the physician. Today, the medical students talking will be me, Isha Doshi, an MS2.
Hi, everyone. My name is Drishti Patel, and I'm also an MS2.
And our law students accompanying us today.
I'm Taylor Bacon, and I'm a second-year student at Albany Law School, and I'm currently a legal intern at the Family Violence Litigation Clinic.
Hi, I'm Danielle. I'm also a second-year student, and I'm also in the Family Violence Litigation Clinic with Taylor.
I'm Chloe Ross. I'm also a second-year law student and also a legal intern at the Family Violence Litigation Clinic.
The faculty advisors for our presentation today were Professor Barrett. She's the visiting assistant professor of law and the director of Family Violence Litigation Clinic at Albany Law, and Dr. Kirsten Morrissey, who is the assistant professor in the Pediatric Emergency Medicine Department and also the medical director for the Sexual Assault Forensics Examiner program here at AMC. We just wanted to let everyone know that none of the speakers today have any financial disclosures. So kind of just an overview of what we're going to talk about today. First of all, kind of reporting what we see in the status quo in our current literature about the severity of the problem, what strategies are currently being used by physicians, and how can we better implement those solutions and implement them by evidence-based medicine. This presentation is also an ACCME approved presentation. So just a roadmap of where we're going to be talking about today. We'll be establishing the status quo, talking about the biggest medical complications we see in IPV victims, address the screening tools and the limitations or benefits we see with these, and the law students will be helping us look at avenues for change in which physicians can help better this process, followed up with an open discussion on kind of commentary on what we see in the status quo today. I'd like to take it away to Danielle, I believe.
Thank you. Hi, everyone. So this slide is a brief overview of what the status quo currently is for IPV. According to statistics that we have looked at, 1 in 4 women and 1 in 9 men will or have experienced intimate partner violence in their lifetime. And this violence is not only physical, there's also emotional, psychological, and other forms of violence that are quite pervasive. Furthermore, looking at what this actually looks like day to day, nearly 20 people per minute are physically abused in intimate partner violence relationships in the United States. Also, during 1 year, this equates to more than 10 million women and men that are abused. So there is quite a pervasive impact of IPV relationships, and this ends up being in PTSD, suicide, life-threatening injuries, STDs, and more. So the question is, why are we here? And this slide is a little complicated because the nature of IPV relationships are incredibly complicated. So the big 3 things that we see are fear and control, psychological trauma, and physical trauma. And what's important to know is that they overlap quite consistently. So you'll see different mental health issues, limited autonomy, impacts on women's health, and of course, physical injuries. But what's important to know is that each of these pathways can lead to death. It is statistically more likely that a survivor will be killed once they leave the IPV relationship. So what we want to make sure we do is focus on 3 areas that we really thought were very impactful, and we are going to start that on the next slide.
So the biggest complications that we saw when reading through the medical literature was depression and mental health issues, traumatic brain injury and chronic encephalopathy, and strangulation. So we're going to be going through all 3 of these complications and kind of looking at what the medical literature has to say about it. So trying to associate IPV with any medical complication is already hard enough because it's hard to see which attacks are directly correlative to specific symptoms. But in this meta-analysis that was done in 2019 by Caillou Han, he looked at both IPV incident-based depression and depression-based IPV. And so the biggest one that stood out to us is the one here in the red box that showed the statistically significant odds ratio of more than 3 times, which means that there's a positive correlation in both directions, but especially what we need to focus on as physicians is looking out for and screening all of our depressed patients for IPV and vice versa. And I think that's a really important thing that needs to be looked at and added to in our normal screening process.
So we also looked at traumatic brain injury and chronic encephalitis. There's currently no screening tool that physicians can use to identify TBI specifically in instances of IPV. But unfortunately, TBI is a very common complication of IPV. Empirical studies that we looked at reported a rate of TBI present in IPV victims ranging from 19% to 75%. The meta-analysis that we are featuring on our slide was done in 2011 and tried to analyze what symptoms and signs clinicians should look for in IPV cases to suspect a possible TBI. As you can see, different studies have evaluated different factors, amplifying the fact that there is no standardized approach for how we screen for TBI. This can lead to a large variety, this has led to a large variety of rates that we've seen in the literature. In addition, even for each symptom, the range of patients who report for each specific symptom varies greatly. For example, if we look at headache, one study reports that being a symptom of TBI in their patient population at 18%, whereas another study reports that 75% of their patients reported headache as a symptom associated with IPV. So it just calls again to the clear need that we have for a standardized approach. Lastly, one major sign to look out for in cases of IPV is the presence of strangulation. Unfortunately, strangulation might be easily missed by clinicians, and patients might even report to the clinic after being strangled on multiple separate occasions. This is a graphic that we found on strangulation. It's very jarring, and it shows some of the possible signs and symptoms that a patient might present with who has been strangled. Some of the signs listed on the slide were ones that we felt were important, but might have been easily missed or not as obvious. These include bruising behind the ear, bald spots from hair being pulled, fingernail impressions on the neck and the face, and bloody red eyeballs. Just like we've seen with the other two medical symptoms that we focused on, there's a lack of medical literature on strangulation as well. Studying strangulation can be very difficult as it's often used as a factor to examine domestic violence, with very few IPV-specific studies. As clinicians, it's really important to recognize the medical complications, especially since patients might be presenting with multiple instances of strangulation. These graphs that we have shown provide an understanding of the frequency of symptoms associated with strangulation. So on the images where there are asterisks, there's a statistically significant difference in the symptoms reported between IPV victims and non-IPV victims. So the ones that we wanted to highlight have been boxed. This meta-analysis splits symptoms into general, psychiatric, and neurological symptoms. In the neurological section, memory loss is something that we thought that clinicians should look at. For the general one, there were quite a few symptoms, but we really wanted to emphasize the voice changes. And lastly, for the psychiatric portion, the only symptom that was significant was the presence of nightmares. And then I'm going to be passing it on to Chloe to talk about some of the screening tools that we have.
The most common screening tool for domestic violence is the question, do you feel safe at home? The question has a sensitivity of 8.8% and a specificity of 91.2%. So this means that only 8.8% of domestic violence victims screened positive for DV with this test, and 91.2% of patients that are not experiencing domestic violence screened negative. Because an effective screening procedure should be able to identify victims of domestic violence, a better, more thorough screening procedure is necessary. An alternative screening procedure is called HITS. HIT stands for hit, insult, threaten, and scream. The questionnaire scores how often the patient's partner hits, insults, threatens, or screams at them with a 5-point scale for each question. If a patient scores more than 10 points, they've screened positive for domestic violence. A score of below 10, even if the physician found it to be suspect, does not constitute a positive screening of domestic violence.
So we tried to find as many studies as we could that looked into HITS, and this is the most recent one that we've found from 2021 by DMarquis, and it found that more than 80% of its participants reporting physical violence didn't actually screen positive by the HITS system. So if you look at the image on the right side of the screen at the top, out of the 1,014 participants that we had, only 7% of them had a presence of physical violence, but of that 7%, only 18% tested positive under HITS. That leaves 82% of your participants that did experience physical violence but didn't test positive under HITS. The image at the bottom is the same thing but for verbal violence. And so this shows a really large discrepancy in this specific screening tool. But mind you, these are screening tools that are recommended by the CDC. These are the screening tools presented to you today are what we have as the best forms of recommendations for what physicians should use. And this shows a glaring disparity between the true positives and what we're actually seeing from these screening tools. Another really big point that this paper made was that participants who reported any form of violence already had a lower baseline trust in their clinicians. But not only did that happen, but it also worsened and reported higher rates of healthcare-based discrimination than respondents who didn't have any episodes of violence. And the biggest reason that the paper finds for this is follow-up. Even if an incident of violence was reported, the lack of follow-up by a physician continued to push this distrust in healthcare-based systems and practices because it didn't make it seem like it was a big enough problem in their life. And the lack of follow-up is a central part of this entire paper, probably likely caused by screening tools like HITS.
WAST, the Woman Abuse Screening Tool, asks a patient 8 questions about their relationship, which you can see in the picture on the screen. WAST SF, the Woman Abuse Screening Tool short form, asks only the first 2 questions of WAST, which asks how they would describe their relationship and how they work through their arguments with their partner. Unlike more rigid scoring system, like they used in HITS, a positive screening relies solely on the physician's clinical judgment.
So unfortunately, we weren't able to find a lot of big center medical literature studies from the United States. But when looking at the population in France, this had a sensitivity of 97% and a specificity of 97%. Out of all of the screening tools we've seen, this had the highest success rate. But if it is one of the best screening tools we have, it's kind of shocking to see this wide gap in the medical literature of the efficiency of this. Not only this, but in its name inherently, this is also a screening tool that's targeted to help women and does not necessarily mean it's applicable to men, while it should be. This paper also points out that true victims of violence are 34.2 times more likely to be classified as abused than true non-victims, which is probably the best we've seen, but it's kind of sad that we don't have any explanation as to why this screening tool may be better, but also we're not seeing it being implemented. It's not something that's been implemented across the United States, but we do see our European healthcare systems implementing this more.
With the partner violence screen, a patient is asked 3 questions. If the patient answers that they have been subject to physical violence in the last year, or if they feel unsafe in their relationship, or a previous partner is making them feel unsafe, then they have screened positive for domestic violence. So PVS is really unique because the psychological factor, how safe the patient feels alone, is enough to indicate domestic violence, as opposed to relying on an overall score like with HITS or the physician's clinical judgment like with WAST and WAST SF.
Just like the other studies, we tried to evaluate how great PVS is. And it was actually very hard to find literature on PVS, but the few studies that we found show that it had a sensitivity of 35 to 71% and a specificity of 80 to 94%. One of our studies showed that when it was introduced in the emergency department, it greatly increased the chance of recognizing IPV. One of the greatest merits of the PVS tool is that it's only 3 questions. It's very quick to do in an emergency department setting. But however, there was a false negative rate that was higher in men that ranged from 14 to 33%. So about 14 to 33% of males were not being tested as positive and were falsely being tested as negative. Something else that this tool was important for is that it might show some long-term effects or follow-up. And so they found that patients who screened positive under PVS were 14 times more likely to have experienced physical abuse 4 months later. So when using this tool, it's really important to follow up with the patients that you're evaluating.
So now we're going to move the topic of conversation to trauma-informed care, and I believe Taylor will be taking the floor.
Thank you. So yeah, this is a brief introduction slide to just segue into the information that is trauma-informed care. So you can just click. Okay, so we're just going to start with the basics. This is straight from like trauma-informed care website. And the first thing begins of like, what really is trauma? And it says results from exposure to an incident or a series of events that are emotionally disturbing or life-threatening with lasting adverse effects. So either a single incident or multiple incidents could impact almost every part of an IPV victim's life. And the second one is healthcare organizations and care teams need to have a complete picture of a patient's life situation, past and present, in order to provide effective healthcare services. And adopting trauma-informed practices can potentially improve patient engagement, treatment adherence, and health outcomes, as well as provider and staff wellness. So it's kind of like your priority to provide your patients with care. But when you're working with patients who have experienced trauma, it's extremely easy to accidentally re-traumatize by bringing up sensitive topics. But using trauma-informed practice and techniques, it's less likely to re-traumatize, and it'll strengthen the relationship you have with your patients. So this is a study that kind of talked about what does it look like in practice and how your medical community can recognize and kind of change the way that you're screening patients to make it more trauma-informed. So the first thing is agency, and it's always important to remember when you're working with patients that it's their personal choice. And although some things that you're hearing may be jarring, you know, like the cycle of returning to abusers, it's their choice and you need to respect where they're at and make sure not to coerce information they're not ready for to prevent re-traumatizing them. The second is information. So providing your patients with resources, statistics, and commitment to follow-ups or opportunities can help increase that trust and create a supportive relationship. And make sure to help them understand what trauma is and can cause. We talked about the health effects that it can have to make sure that the trauma that they experienced could cause depression and anxiety or impact and worsen the depression and anxiety already present. So building off of that connection is just developing a supportive role with your client. And then strengths, reminding your, patient client that although, this traumatic experience happened to them, they're an extremely strong person, and making sure that, you're just there to listen sometimes. They're often not believed or dismissed, and making sure that their provider, sees them as a strong person is really important. Inclusivity. You interact with a lot of different people every single day of different backgrounds, socioeconomic statuses, cultures, religions, and just making sure to, even though you may not, have experienced their experiences, like acknowledge that and make sure to kind of, again, meet them where they're at. Parenting, the last one, is in IPV, sometimes, it happens within the family and it happens with children in the home. And make sure to help them, do what you can to strengthen that relationship with their children. The children could be caught in the middle or experience their parents arguing, and it can't be it can't be easy for the children or the parent that is the victim to know that that's happening in the household, to just make sure that you acknowledge that, it's important to strengthen that parent-child relationship.
So if the patient does screen positive for domestic violence, the physician then has to assess the risk of immediate harm. So if the patient responds yes to 3 or more of the following questions, they are considered to be at high risk of immediate harm or injury. So the questions are, has the physical violence increased over the past 6 months? Has your partner used a weapon or threatened you with a weapon? Do you believe your partner is capable of killing you? Have you been beaten while pregnant? Is your partner violently and constantly jealous of you? So then patients at a high risk of immediate harm or injury should be offered safety planning information and other resources at this point, which Dan is going to talk about now.
Hi everyone. So we have gone over a bunch of tests and options that are provided, but the question is, what are we to do when we actually have the patient in front of us? And the answer is that as a physician, you are able to provide support to victims. And what I have here is a couple of options that from research have been proven to be effective with survivors. And the acronym you can kind of remember is SIDD, support, inform, discuss, and document. And what's really important with these is that we're going over each way that you can really make an impact with the survivor right in front of you. So with support, you're able to talk in private, identify any risk factors such as weapons or threats or anything like that. And then with discussing options, you're able to go over with the survivor. Do you have a way to get out? Are you going to be safe when we leave? Is your abuser here with you? And be able to start a safety plan with them. Finally, with inform, you're going to want to be familiar with local organizations that will be able to provide survivor support in getting out of an abusive relationship. And I'm actually going to provide those to you in a second. But another really important area that you can provide support is through documentation. So describing the behavior in detail given by the survivor in your reports is extremely important because that can aid the survivor in future litigation if they want to pursue that. So things like, was there a handprint mark or was there strangulation marks? Those are really important things that if they're in the report, then the survivor is able to utilize that if they want to pursue accountability for their abuser. So as promised, these are some resources that are in the capital region that it's really good to be familiar with. We have Albany, Rensselaer, Saratoga, Schenectady, and also legal assistance. So if anyone wants to screenshot, feel free. You can also Google all of these and you will be able to find more information.
So to try to kind of sum up what we wanted to get across in our presentation today is kind of highlight that this is an issue and we don't have enough medical literature, but as a community that's moving towards evidence-based medicine, the best thing that we can do is analyze what we're doing in the status quo. And so things that stood out to us when we did our research, populations that are historically underscreened. We didn't find a lot of information on IPV or DV in LGBTQ communities, but also the rates and how to deal with it in men. There's a really large gap in how we can address these issues and if there's a difference in how we need to address these issues between different genders, different sexes. Secondly, the association between child abuse and intimate partner violence. Is it more likely for a victim of child abuse to go into a toxic or intimate partner violence relationship? And does the vice versa also exist? But lastly, implementation strategies on how to actually educate the medical community on this. As the only people that will consistently see these patients, whether it's through primary care or through any other kind of medical issue, there's a responsibility that we hold as physicians to be those people who are screening for it, who are looking for it, and who are looking out for their victims and asking the right questions. And so as the medical community and as medical students, we wanted to ask the question, what can we do more? And with the help of the law school, we can educate ourselves and try to figure out what those options are and if there's anything left to do. Because I know that that issue is not solved in the status quo today, and we as a community want to do more. AMC has started in this push towards trying to figure out where those holes are. Dr. Morrissey, Kaylin Dawson, and Haley have all created a intimate partner violence survey. It was sent out a few weeks ago, but if you use the QR code on the screen, you can also access the survey. It's part of a project that's centered around developing an educational program that aims to improve this screening process and see what the responses we would get from physicians would be. Essentially, they're trying to collect some baseline data regarding the current practices, how comfortable our community is, and how much knowledge do we actually have on IPV, on the status quo, and how to ask those questions and use those screening tools. If you or someone you know is experiencing domestic violence, this community is very strong in helping for that. So this is the hotline. Please write it down. Please send it to your patients, any clients. It is available online, but we thought we would put this resource out here just in case. And this sums up our presentation. We wanted to thank Professor Barrett and Dr. Morrissey for being our faculty advisors, and Dr. Coates and the Community Grounds leadership for helping us put this presentation together. I'd like to now move into the open discussion section of this presentation, and I'd like to give the floor to Professor Barrett and Dr. Morrissey. If anyone has any questions or discussion points, please feel free to unmute yourselves and say what you'd like to say, or put it in the chat, and we'll be going through those questions.
I can start with some of the medical. Hi, I'm Kirsten Morrissey. So my background is actually in pediatrics. I did my residency training in pediatrics and then did additional training in pediatric emergency medicine. So my initial interest in IPV was really, initially stemmed from sort of my interest in child maltreatment and sort of just overall family dynamics in the home for pediatric patients. We know that IPV is a significant risk factor for child maltreatment, and we also know that children that are exposed to IPV are more likely to have issues with mental health down the line, and sort of some of that trauma that we talked about that can have a long-standing impact. We also, sort of the longer I've been doing this, the more I've realized that adolescents are also sort of experiencing IPV. The more we ask about that in younger patients, they are in abusive relationships as well. So that's sort of another area that we're not necessarily regularly screening for, and we sometimes forget about. And patients that sort of are, child maltreatment, that are victims of child maltreatment, are more likely to be in, IPV relationships. So we could probably spend, a whole hour discussing some of that. But I definitely want, for the medical students there, regardless of what specialty you go into in medicine, you will have patients that are impacted by IPV. So really important that you are all familiar and comfortable with that. I thought you guys did an excellent job talking about many of the challenges with screening, and the biggest is that we don't really have a good evidence-based screen. I was always shocked to sort of hear how low the sensitivity for that standard question that we all learned was. It's really not a great question, but we do know that asking more specific questions is more likely to get us more information from our patients. So rather than those vague, are you safe, asking more specific questions to your patients is more likely to elicit some of that important information. The WASP, the WASP screening tool, I think you guys mentioned, but sort of that title in and of itself perpetuates some of those misconceptions that we have about IPV sort of just impacting women. So although some of those questions I think are great and can be geared towards our patients, it's sort of a disservice that, we have that sort of name included in there. We really try to focus on identifying the barriers to screening and education. So in the emergency department, we don't universally screen everybody, in part because there's not, as you guys mentioned, and as we've learned, there's not a great single screening tool. We really focus our efforts on education. So, Haley's project that you just mentioned, is one of the ways that we're sort of trying to target gaps in our education for staff across all areas in the ED, and then what we can do. I think one barrier for many people is sort of not knowing what that next step is and resources that are available. So really trying to not only make physicians more comfortable with discussion of this, but knowing how to then help our patients make that next step and provide resources. I wanted to also mention, so I'm part of the Sexual Assault Forensic Examiner program. We have been seeing, survivors of sexual assault and child maltreatment for many years, but last year was the first year we started seeing patients that were adult physical violence victims. The program was started last year, but really intended for victims of IPV and domestic violence. And last year, I just looked at these numbers. We saw 95 patients, 83% were female, 17% were male. So still a good number of male patients that we saw with that program. 11% were under 18. So don't forget about those adolescents. Some of those were sort of victims of random violence, but many of them were also intimate partner violence victims. And then 37% reportedly involved strangulation. So you guys talked about the literature around strangulation and all of the medical complications, but almost 40% of those patients we saw last year for IPV related trauma experienced some strangulation. So definitely important to be screening and talking about that.
Hi everyone, I am Professor Hayat Bearat. I'm a visiting professor at Albany Law School and the director of the Family Violence Litigation Clinic. The Family Violence Litigation Clinic at the law school represents both adult and children survivors of domestic violence and their family court proceedings. And so, we see this day to day in the work that we do. Representing them in and out of the courthouse. In my practice, prior to joining the law school, I worked with domestic violence survivors, representing them in New York City. And, throughout the years, there was, when interviewing clients and when preparing for the cases, we saw some of the gaps that were happening in the medical profession and when they obtained medical care. And so this is something I'm very passionate about, and I'm excited about this collaboration between the two schools, because oftentimes this is something that can actually genuinely save someone's life. So asking the right questions, having sensitivity, also just monitoring symptoms after the fact. One of the things that was addressed was that there's gaps in evidence for strangulation. And that's because there's long-term effects for strangulation. So, a survivor that's strangled doesn't necessarily die the very next day, next week, next month. It could lead to serious health complications over the course of the year or years, and then eventually could lead to death. So when we actually screen, clients, prospective clients, and they mention strangulation, this red flag kind of pops up, and we assess that this is a big lethality risk. And what that means is that the risk to their life is a big one. And so in terms of that, these are small little measures that can be taken that can really save someone's life. And so looking out for those things, recommending that they continue to get treatment. If they potentially develop mental health issues as a result of domestic violence, assuring that they have the resources, so connecting them, and just, of course, always never having judgment when speaking with patients. A lot of times the information, I think this was mentioned by one of the students, is really shocking, and it's making sure to really keep a straight face, because the second you react to that information, they could start to pull back and not feel comfortable sharing that. Another thing to share is that I've worked with a large amount of immigrant survivors of domestic violence, and language barrier is a big issue, you know, in and out of hospitals and medical offices. And that's because sometimes, a lot of the times, it's just a language line that's used over the phone. Sometimes it's different dialects. Sometimes it's the education level of the survivor themselves. And so something asking about like whether you've been strangled, they could answer no. You know, this depends on the language barrier, but also just educational background and just really, you know, the knowledge of what that term means. So survivor may have very well been strangled, but not have associated that with the term. And so breaking it down with words and phrases that they could potentially understand better. So as opposed to saying something like, you know, have you been strangled? Or you may say like, has anyone pressed pressure on your throat? Have they put their arm, you know, their hands around your throat? Did you have any difficulty breathing? Did you faint as a result? These types of questions can really help you assess whether strangulation has happened. And so I did really want to, I know, you know, this was mentioned repeatedly, but I really don't want to exclude the populations that are at high risk. So members of the LGBTQ+ community are often completely disregarded, especially for, you know, for male survivors of the LGBTQ+ community. So ensuring that you check your biases, into what you picture a survivor to really look like, act like. They come in all different types of ways. And so coming up with a solution and questioning that is inclusive of everyone. And the last thing I know this was just mentioned was that documenting abuse in the medical records can really, really help the outcome of a survivor's case. So indicating, and this is the case for survivors, whether that be children and or adults, you know, just indicating what you actually physically observed to be on the body, or what, if anything, was shared. You know, sometimes they may say, you know, that this was as a result of being hit, as opposed to just indicating they came bruised. Having actually the details included in medical records are things that can come in at a trial. And these are records that are certified. So the court takes them as this is it. We believe every single thing that's in these certified records. So everything that you include in there is very helpful and beneficial to a survivor's case. So there's things that you can do to help them with their legal cases, but there's also things really, these are small steps that you can take to also just save their lives.
And sort of along that, you know, our forensic examiners, you know, one reason we were really excited to expand to the IPV, you know, patient population is that we can, you know, have, you know, a forensic exam and forensic photo documentation, and do, you know, and our forensic examiners are very used to, you know, testifying in court for a variety of sexual assault cases. So, you know, if you have patients that have, you know, injuries, you know, it's encouraging them to come, you know, to the ED if they want to have that documented. You know, we can take photographs, and, you know, it would encourage them if that's something that they might be interested in later down the line.
I do see that there are a few questions in the chat.
Yes, so I see the question that Tom just asked about, are physicians allowed or required to bring law enforcement personnel for either adult and or pediatric patients? So in terms of, they are allowed to, yes. Are they required to? No. And a lot of times the preference of the survivor is to really not include police officers. So depending on the severity of the domestic violence incident, sometimes you might see patients as a result of the police being involved. So police arrives, you know, someone calls 911, police comes, they get placed in an ambulance, they get to the emergency department, and then the police actually questions them there. That's a situation where, you know, the police is involved naturally based on the circumstances. But Sometimes, physicians do ask survivors and they say, no, I don't feel comfortable, or they feel scared based on their immigration status. That's oftentimes a concern. They might be too scared to have the police involved. So they're not required to bring law enforcement to question them, but certainly can. And in terms of pediatric patients, physicians and anyone that pretty much works in that setting are mandated reporters for so they can report if there's any type of child abuse and or neglect that they note for the children. So that's actually a requirement in terms of reporting it. You can call a hotline to do so. And I can I don't know if you wanted to add anything else to that.
Yeah, so it's a requirement that we report to CPS. It's actually not a requirement that we report to law enforcement. And actually, we're not, authorized to report all these to law enforcement unless they're victims of violence that involve gunshot wounds or sort of stabbings or direct powder burns that are related to gunshots. And in those cases, we do communicate directly with law enforcement. Otherwise, it's sort of CPS and then law enforcement. So a lot of times law enforcement's in the emergency department. We really, don't, we sort of, unless the patient wants them involved or there's those circumstances that I just outlined, we don't communicate with them initially without permission.
And I will say CPS is Child Protective Services. So that's the hotline I was talking about. So when a medical professional notes that there's been abuse and or neglect, then they can call a various hotline. They contact, you'll have all that information, I'm sure, provided to you, and it'll be readily available. And so that's what's a requirement. But yeah, that's what CPS means.
Dr. Coates just put in a comment. I can read it out loud. Dr. Morrissey, this must be very scary for many patients. Please talk about the human side. And then for Professor Barrett, what about those seeking legal remedy? Implies those who don't take that option. Your thoughts on the side of humanity here with respect to how our system works or doesn't work?
Yeah, I mean, I can start. So, I mean, I think it's challenging in the environment that I work in the emergency department. It's very busy, and we, are seeing many patients. I think, in some ways it's easier for, primary care providers to sort of build that rapport and continually sort of discuss this with patients on more of an ongoing basis. But I think these are the cases where even in a busy department, we really need to take the time to support patients and talk to them and families. And I mean, we are a multidisciplinary team, so we, are involving, our social workers regularly. We have sort of child protective agency, for some of the more family and cases. And, I think we also talk about sort of secondary trauma for all of us, providers that see this all of, as sort of day after day kind of seeing difficult cases. And so we sort of have outlets where we, debrief after some of the more difficult cases as a team, people that are involved in the case as a provider, and we'll sort of, as an entire team, kind of debrief about some of these cases because they can be quite difficult and kind of difficult to see, day after day. But we really, I think in these cases, really need to take the time to spend and talk to families and support them however we can.
So regarding those, and I'm not sure if I'm understanding the question correctly. So those seeking legal remedy, whether that might be their decision on whether to file anything in court and or to speak with law enforcement and potentially proceeding with the criminal route. If that's what, and correct me if I'm wrong in terms of that's what you meant by legal remedy. So at the end of the day, survivors make whatever decisions they feel comfortable with. And so it's important, and we talked about this earlier, for them to have agency. They often have very little amount of agencies, in their own lives. And so it's their decision. And so we all have to support what it is that they decide to do. So in terms of, if they decide to seek legal remedies, so let's say they go to court and they want to ask for an order of protection. That's the term used in New York State for restraining orders. And so if they go to court and they ask for this, they usually can get just a temporary relief, and it can be granted without the abuser being present. And then the case proceeds in court. And so this this varies in terms of, a lot of these cases are resolved and you don't end up going to trial. But when you do end up going to trial, I will say this, having medical records and or being questioned as to if they sought medical treatment, if they involved law enforcement, these are questions that are almost always asked as by the adversary as a weakness in the survivor's cases. So if they ended up going to the hospital, that's the way they view it, is like, oh, a point in the survivor's favor. But if they didn't, then they don't believe them. And so if they potentially have had really bad experiences going to get medical care as a result of, continuous abuse that they suffered, they might stop going because of that. And then that could actually end up limiting, that could impact their case. It's not a requirement for them to go to get medical care as a result of injuries, nor is it a requirement for them to file any type of police report or, anything like that. But those are things that help with their case. And honestly, that's kind of like how the system works, or, as you mentioned, or it doesn't. Those are things these are helpful pieces of evidence that can help them be successful in getting a final order of protection from the court. In terms of what is actually, I mentioned this before, but having these like certified medical records and having details in them, and every single thing, I've looked at them for years, everything is noted in those records. And so if a survivor says, no, this is not a result of being, hit by my partner, then that's something that's going to be a point that like against them. So it's obviously understandable. You have to include that. If they are dismissive, if they turn down services, you have to include all these things in your notes. But that's also something that then is like looked at in the court. And so that's not great when we have medical records that show that they, that they repeatedly over the course of years, like they might have sought treatment, but they repeatedly said no. And then maybe eventually they end up saying yes. And so then their credibility gets attacked of like, well, why didn't you say yes before? Was that actually true? And maybe you're lying. Maybe you're doing this now for immigration status or something like that. So that is kind of, there's the reality of the legal side of things that's really complicated. But I will say, if they sought any type of medical treatment, we always get those medical records, because that's so useful in the outcome of our cases. And so getting them is something that's really helpful.
Yeah, one thing we didn't really talk about is just that if a patient or, if somebody's making the decision to leave or to seek help, that might be one of the most sort of dangerous times in that, patient's, that person's life. And in, so that, it's not, so how we approach that and kind of provide resources is really important. And I think that last sort of safety assessment screening that we talked about is really important as well, in terms of, how, we don't want to be pushing patients because we don't know, exactly what type of situation that they are in, but it can be a potentially lethal situation for them if their, abuser finds out that they're trying to leave. So, something we didn't really talk about directly today, but, just being very sort of mindful of, how we provide resources in sort of a non-judgmental way, and especially something that primary care doctors can sort of, discuss on regular visits if they sort of, know that the patient is in, an abusive relationship, but it might actually be a very kind of dangerous time for them. So keeping that in mind as well.
I know that sometimes what we're doing in primary care is really providing social support and validation. And the end goal can't be whether or not the person remains in the relationship. That has to be up to the individual. So I thought this was a wonderful panel, and thank you for emphasizing that leaving a relationship is a process, and it's not the metric by which we judge our success. Sometimes our success is just providing support and validation to that individual. I also noticed that you all alternated between using the term victim and the term survivor. And I, over the years, have learned to avoid the use of victim. I know that it's a legal term and that it has a firm definition, but I do think that patients often prefer hearing survivor, which I heard many of you use as well, because patients often don't want to feel like victims. And when we use psychosocial rehabilitation language, we avoid victim and batterer and perpetrator, and we move towards person who has experienced violence, person who has used violence, because both of those people need treatment. So I thought this was a wonderful panel. Thank you.
Thank you. One of the things that's a great point. I'm glad you brought that up, is that we always say this to our clients and we always ask them, how do you want to be referred to? Because sometimes they actually don't like the term survivor. Sometimes they, so it's really listening. And a lot of this work is listening to what their needs are, having no judgment along the way. Some like to be called a victim. They feel like it. That's what they maybe have been involved extensively in criminal prosecution, and that's how they're referred to in those cases. And that's what they're comfortable with. So following their lead in terms of what they say, and always asking them how they want to be called. But yeah, I'm so glad you brought that up.
I think the same thing also goes for documentation. I mean, I'm coming recently from VA, where we had a national intimate partner violence assistance program. And we would obtain consent for documentation in medical records. So again, just being really patient-centered. And yeah, I mean, if somebody likes or prefers the term victim, if that suits them at the time, absolutely, we shouldn't be telling patients how to, how to refer to themselves.
Dr. Gerber, would you mind introducing yourself? You're so very fluent in this topic. I was just wondering if you could tell everybody about your background.
Hi, everyone. I'm Megan Gerber. I have recently joined the faculty at Albany Medical College, and I did get my sort of start in the intimate partner violence world years ago when I was working in Cambridge, Massachusetts, and I worked on something called the Domestic Violence Free Zone because I was at a public hospital. I ended up doing a research fellowship in a psychology family violence lab and did a lot of work on assessing and identifying and working with trauma-exposed women in primary care. And over the last few years have really been working on trying to teach trauma-informed and trauma-sensitive methods of medical care to clinicians because, as all of you so eloquently pointed out, one form of violence typically is not the only form of violence an individual has been exposed to in his, her, or their lifetime. So I thought this was a wonderful panel, and thank you.
I just wanted to say thank you to Professor Barrett, Dr. Morrissey, and Dr. Gerber. I wanted to ask, in your personal experiences, what do you think would be the best way for the community to do going forward? What is something that you think on an individual basis people can definitely improve on?
I'll say starting out with education, doing exactly programming like this. So attending, making sure that we all continue to just educate ourselves on the various topics that even ones that we think we're familiar with, just keeping up to date, just so that we make sure that that we're addressing the needs of survivors. And so continuing education, but also really practicing what we talked about today. Some of these are really, really simple steps. So practicing non-judgment, listening to the words in the language that you're using, breaking down language so that you're not using, we say this a lot as attorneys, don't use legalese, but same thing, use terminology that they're going to understand and maybe not be intimidated by, and just document, ask questions, having sensitivity, and when you're asking those questions, and really listening when they're answering, because they might say one thing, but then it might be very clear that they're holding back from sharing something. There might be something that's holding them back, and so maybe giving them a break and coming back and resuming questions. So things like that. But my hope is that we can continue to collaborate together between the law school, so my clinic, and also the medical, college, and to continue to do these types of programmings, covering various topics. I know Dr. Morrissey mentioned this, but like covering children, that's a huge area we didn't get into at all. And so I encourage you to continue to challenge yourself, educate yourself, and that will be a really helpful step in helping survivors.
Yeah, Dr. Gerber mentioned that survey you sent out that Haley is working on. It was really just for the ED. That's where we're sort of basing this education project. But we are always looking for, people who are interested in expanding projects into other departments and divisions and primary care settings. And the other population we didn't really talk about was the obstetric population, and pregnancy is a very high risk time for intimate partner violence. So if you are interested in sort of working on projects in any of those areas, we would love to kind of assist you, help you, and kind of mentor you with some of those.
The only thing I would add really quickly is that asking, first of all, kudos to the students for seeing that 15 minutes is not enough. Like, you are driving a really important change in the curriculum. Asking is opening a door. Asking is an intervention in and of itself, right? Because so often, and I'm sure Dr. Morrissey and others in the emergency department have seen this many times, you get the no, or I don't want to answer that question, and then they come in and they say, remember when you asked me this? I've seen that so many times, that you're basically letting a person know that this is a safe place. This is a place where they can share this, that it belongs in a medical setting, it belongs in a legal setting. Because often, as you all pointed out, they're isolated and they're disempowered, and being asked, I think, is really, believe it or not, an intervention, even if you get no or no disclosure many times.
Yeah, and other things that have been shown to be effective, I mean, there's signage in bathrooms and patient care rooms, and we have sort of in our restrooms, if you need help, what to do, how to, we have ways of getting patients alone and separated from partners that may be the perpetrators that are there with them. So, I think even things like that in your settings can be helpful too.
And I can't forget to say this, but connecting them to resources. So whether that might be mental health resources, that is always the first step we want to take, because if they're living with the abuser, they might eventually be able and ready to leave and or set up the right safe plan to do so if they have the resources in place. And so I can't describe the number of survivor clients that I've had that were able to eventually safely leave the home because of the resources.
Does anyone have any other questions or discussion points they'd like to bring up? Okay, I think that about wraps it up. Thank you so much for listening to our presentation tonight. Thank you, Professor Barrett, Dr. Morrissey, Dr. Gerber, and Dr. Coates, the entire Community Grand Rounds team. This was a great initiative. I'm sure the students, we all loved working together, and the hope is that we do get to implement something in the future. We've been trying to put together possibly a service learning in which we could have the law students help teach the medical students and the faculty on how to address domestic violence survivors and victims, and somehow be able to set up a clinic possibly with Unity House or Equinox. But we do need a lot of support. We are looking for physicians that would help us with that, and try to help us put it together. But this was our preliminary introduction into the issue, and we don't want to leave it here. We do want to continue. So we look forward to doing more, and thank you so much for attending.